Coming toward the long-term anticoagulation. The long-term anticoagulation. A person is out of acute condition. Now, two questions are there. For how long you will give anticoagulation, and what anticoagulation will you give to the patient? So we are having two things: provoked pulmonary embolism and unprovoked pulmonary embolism. These are two very important topics. And similarly, the treatment and management of the DVT is same as that of pulmonary embolism. So provoked DVT or unprovoked DVT, the treatment is the same. So provoke means there is a cause, there is a risk factors, and this risk factor is avoidable. You can avoid or you can remove that risk factor, and if that risk factor is removed, then the risk of pulmonary embolism is decreased significantly. So such as pregnancy, avoidable; immobility, avoidable. So these are the provoked pulmonary embolism, in which there is such a risk factor which is avoidable. So the answer is 3 months. The long-term anticoagulation in provoked pulmonary embolism, that is 3 months. But assess again at 3rd month. This is very important. At 3rd month, assess again whether the person is improved or not. Point number 1. Clinical improvement as well as radiological improvement. If the person is improved significantly, clinically and radiologically, stop anticoagulation. Stop anticoagulation. But if there is no improvement, address the risk factor, whether the risk factor is removed or not. Point number 1. Point number 2, think about prolonging the anticoagulation. Prolong the anticoagulation till 6 to 12 months. 6 to 12 months, and at 6 months again reassess. And if these things persist, then prolong till the 12 months, and at the 12 months again reassess. Maybe the cause was that of unprovoked, and we have wrongly diagnosed it as a provoke. So there may be a possibility. Usually the provoked pulmonary embolism resolve within 3 months. Point number 1. Point number 2, they do not require long-term coagulation because the risk factor is removed. Now coming toward the unprovoked pulmonary embolism. In the unprovoked pulmonary embolism, you did a lot of investigation and you found no risk factors, or there is a risk factor present but that is unavoidable. You cannot avoid that risk factor. That is cancer that cannot be treated. That is antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. So if the case is unprovoked pulmonary embolism, the anticoagulation will be lifelong. Lifelong. Now coming toward the second question, what will you give as an anticoagulant? Heparin, warfarin, or oral novel anticoagulants such as rivaroxaban, apixaban. So coming toward that, patient is not pregnant, GFR is more than 30, and there is no active cancer. The answer is, and the patient is having pulmonary embolism, the answer is oral factor 10 inhibitor such as rivaroxaban. A person is having creatinine clearance of less than 30, avoid factor 10 inhibitor such as rivaroxaban. But you can give this factor 10 inhibitor, that is apixaban. So you are having two options in case of creatinine clearance less than 30, the warfarin and the apixaban. If a female is pregnant, you are having two options, the heparin or clexane. You are having two options, the heparin or clexane. If the person is having active cancer, the answer is heparin, enoxaparin, heparin or the clexane. So we discussed the two main things: for how long you will give anticoagulation, provoked and unprovoked, and then we discussed which drug will you give. So this was for excluding these three things: rivaroxaban. If creatinine clearance is less than 32 options. If pregnancy, inactive cancer, the heparin or enoxaparin. Now a patient is admitted with the pulmonary embolism in your ward. How would you say that this person pulmonary embolism is of severe nature? So indication of severity, you would look for the trop-I and trop-T and the proBNP. If these two things are high, it means mortality of this pulmonary embolism is very high, because there is a right ventricular strain. If there is embolism, so the right ventricle, it cannot push the blood against the high resistance. If it cannot push the blood against the high resistance, so there is a right ventricular strain. There is a right ventricular strain, and whenever there is a right ventricular strain, so it releases trop-I and trop-T into the blood, and also the proBNP into the blood. So these are actually the markers of severity. And on the ECG, if you can peck, or on the echo you can peck the right ventricular strain, that is the indication of severity, that this person is having more severe pulmonary embolism and this person is going to die because of the high trop-T and I and high proBNP, that is related to high mortality. So what are the complications of pulmonary embolism? So there are two sets of complication. One, complications related to the disease. Second, complications related to the treatment. Complications related to the disease is, number one, early shock. The increased mortality in the early, that is for less than 10 days. The first 10 days of pulmonary embolism, the mortality is due to shock. And we have to monitor the BP. That is very important. We have to monitor the BP. So we have to prevent the shock in the first 10 days. The late complication due to the disease is pulmonary hypertension. That is actually pulmonary hypertension due to recurrent pulmonary embolism. So you have to look for the echo with PAP. Echo with PAP. Echo with, this is pulmonary arterial pressure, because it can cause pulmonary arterial hypertension, which can cause cor pulmonale. And the complications related to the treatment, point number one, bleeding, because the patient is on anticoagulation and there is a risk of bleeding. And if there is a risk of bleeding, so those patients which are on oral factor 10 inhibitors such as rivaroxaban, it is very difficult to reverse them, because that antidote indexinate alpha is not present in Pakistan. When if the person is on warfarin, we can reverse it quickly by giving FFVs, vitamin K in the blood. Number two, treatment failure. Treatment failure. Either the dose was not fine, or the person was using some drugs and there was interaction of their drug which causes increased metabolism and clearance of rivaroxaban and causes the treatment failure. So this was the complication regarding to pulmonary embolism, and this conclude all lecture regarding pulmonary embolism. I hope you enjoyed it. Thanks for watching.